Hello, I am Wiyengis Woton Agada.
Hi, I'm Chidima Onozu, and this is
BHIS, health our priority.
BHIS, committed to your health needs.
So the next one is about challenges and the reality that's coming and dawning on us. There is a surge, um, and we already know that the clinics are feeling a bit of the heat here and there. So the question would be, how do these challenges affect patient care and performance and staff performances? Because now we know that if there is a intake of more patients, there's going to be change in staff behavior. There's going to be a change in clients. I say clients in give me the word. Patients in workload, yet, and how patients respond. Do you understand? And we have a leader here. Professor is a leader. We cannot disembark that. So, sir, how do you? You already mentioned one way you wanted to. You had stated that you dealt with it. That was creating space for more capacity. But when it comes to the fact that people know that BHIS provides what do they call it? Something, can you help
Capitation.
me? Capitation. For this, I don't know, I'm missing words for this, but we know that when these informations get to the staff, they are expecting maybe their own share and stuff. How have you been able to deal with this? What do they?
Expectation.
This expectation, this approach, because a lot of staffs in hospitals, in the understanding this scheme, would want to ask for compensation. So how do you deal with approaching this issue, especially from the staffs?
Thank you very much. You know that you know what's going on in the country.
Yes.
There is these are local palace, Japa. So, we have a shortage of health manpower. It's affecting the whole country. Most hospitals. Specialized nurses, specialists, especially in areas like anesthesia, or even pediatric surgery, physiology, a lot of specialties. We have that challenge. And even the resident doctor, recently, the government even made approval for I think, employment 2023 in these state years hospital. We do not let some residents that which form the bulk of the workforce and things to some departments. That's we could not get enough to some departments. So that challenge is why it's there. It's the challenge is there. How do we cope with it? It's by encouraging our staff. We also talk to the patients from time to time to have some level of understanding.
Okay.
Yes, because sometimes there could be increased waiting time.
Increased waiting time.
Yes, for patients that they will just want to just come and be attended to immediately. Because when your patients are many and you have fewer health manpower to handle those number of patients, it requires the patients to have that understanding. Also, the doctor, we have taught them how to triage. If you have, for instance, you're in a state emergency and you have one or two doctors, casualty, in the emergency, and then we have too many emergencies coming at the same time, for instance. Instead of triage meaning that you assess the patient and you attend to the most critical ones before you get it. So there are certain ways that certain measures that we put in place to ensure that we overcome that to some extent. And so communication is key.
Okay.
Communication is very, very key, and this is something that we've been emphasizing in our hospital. doing our orientation, new intakes, and even our departmental programs. We'll be emphasizing that. That's how you communicate to the patients. The patients are telling them that this, please, your approach, your model approach, even calm them down, calm them down. And some of them get, sometimes even they react abnormally to delays and all that. So that's something that we are also doing because we are aware of the challenge. And the other aspect is about expectation. It's normal for most of our. It's almost like becoming a normal thing. I'm not saying that it's just a normal thing globally, but it's not almost becoming a normal thing for people to have some level of entitlement.
Okay.
Entitlement mentality. Especially people that are even working in the insurance department. The BHIS, we have the insurance unit. Okay, so people may have some level of expectation. Expecting bonuses, expecting additional pay, and all that for services that we are having. But it's quite challenging for us. It's quite challenging for us to, accede to all requests. It's quite challenging for us to accede to that request because of the fact that if you are influenced, to just approve certain amount of allowances, for some set of workers in the hospital, to other clinicians, other people that are giving us, so the clinical service will also complain. So something that we are very circumspect when it comes to just giving, a form of bonuses and all that to encourage people. However, as a hospital, we have welfare packages generally.
Okay, we have welfare packages already in
for
place.
our workers, yes. So, for instance, we are the only health facility, not just the health facility in the state, that we provide free transport services for our staff.
Wow.
Yes. So, because our hospital is not in town, it's at the outskirts. It's quite it's a distance, only 45 minutes drive from me. The cost of transport. And we have 2 coastal buses that we spent millions of naira maintaining and fueling to ensure that we do that for them. So don't pay any company for transport. Yes. That's one way we encourage them. We also, if somebody is bereaved, is a direct relative, parents, husband, spouse, and all that, we also, do the needful by assisting. Then somebody wants to, minister wants to go to attend the conference, and all that, because it teaches people go for updates, training here and there, to even improve skill. But we reflect on positively on service delivery. We also, assist.
Okay.
So we do the general welfare for program. We have this general welfare program for the staff, and this sometimes this entitlement mentality. Sometimes some people take it to the extreme expectation. They are social money is coming in because we run open government. So this amount of money, but sometimes they don't realize what is spent. This money that is coming in from BHIS, look at our drugs. But for the money, how much drugs have we? How much money have we spent on drugs? How much money have we spent on diesel? Diesel most of the time. The generator is supposed to be a backup.
Yes.
But now generator is even the
main
source of
electricity.
So you know what it means using the generator to run any facility. So that you have that, misunderstanding. Sometimes people may just feel that they should have, some more allowances aside from what government is paying to them. But we try to make them realize that, and the more you are open as an administrator, you're open to your staff, telling that this is this. I think it may make them to understand the situation better. So that's the way we are going about it. And so far, we've not had any very, very serious issue with regard to that. No, I've not heard that somebody has left his duty post because he's not giving bonus.
Okay.
Because we found out anybody doing any sharp practices in the hospital. As we speak now, there are two staff are even on suspension because they doing sharp practice like that.
All right.
So we try to maintain some level of decorum in the workplace and encourage and communicate effectively with them to have this understanding.
That's amazing.
All right, Prof, you made some very vital points. I think the key takeaway from what you said is communication. You say communication is key, and then secondly, you said as an administrator, transparency and accountability is also part of your watchword, part of the things you do. So for me, that is profound. Now the question is, these complaints, because we have something we do. It's called BHIS on the street. What we do is we go on the street to get unfiltered feedbacks from enrollees. By the reports we are getting, it appears that they are the one feeling the brunt of the nonchalant attitude of some of the health workers in the respective facilities, especially government-owned hospitals, based on the fact that they have some level of immunity as regards their job. So the question now is, because it boils down to so many things. You said increase of waiting time. It's something I actually wanted to speak. There's another problem that has to do with treating BHIS enrollees as, let's say, second-class patients as compared to patient that pays out of pocket. Like there's a preferential treatment given to patient that will just come into the facility that is not under the scheme, that is given a sort of preferential treatment. Then BHIS patients would have to wait for a longer period. So it is now tied to, it's like a chain of so many problems, because it's creating problems. Will succeed at one point, the success record will now be eroded, in a sense that we have patients coming to the hospital because of the scheme, and now they now go to the hospital, they have to wait for longer time. With that experience, they feel so bad and then see no need why they should even go to the hospital in the first place. So these are the issues of, and it's going back to the attitude of the staff. So in my head, what I know is, sometimes we should try to understand from the staff too. Probably they are overwhelmed with work because of the surge of the numbers. That is trying to understand them. Let's create a nuance of the whole thing. And then secondly, if I'm working extra hours, what am I getting? What are the incentives? You mentioned one about boss.
Yes.
But people would feel they still need more. Entitled mentality is there, but then at least I should still see why I should work extra. I should be encouraged for working extra hours. So these are the concerns I want you to address. I think I know I've mentioned so many things.
Thank you very much. I think just as my brother stated, we have what I would call a poor work culture among some of the civil servants generally. It's not really limited to that. Yes, it's a poor work culture. Some people believe that they should just remain wherever they are. To them, they should not even come to work and they should receive alert. But that kind of poor work culture is there among some staff. It's not something that I would say that is exhibited by all our staff, but there are some people that may have that kind of poor attitude to work. How do we deal with it as a management? Most of the time, the core medical personnel, if they are absent from their duty post, it will be quick notice quickly. Yes, quickly. Just let me tell you what happened just few days ago. A doctor was supposed to be on duty, running shift in the accident emergency. So he was supposed to take over from someone that did night. The person waited and waited, and the person left without handing over to the other because there was delay. So that time interval, patients that came in had some issue. We got information. It's about trying to put in because you cannot really change people's attitudes overnight. Because some of these things are inborn attitudes. So you have to put in measures in place to ensure that even when those people, somebody exhibit that kind of attitude, you should be able to put in measures to ensure that does not affect service delivery negatively. So immediately information got to the CMAC and director of nursing. The HOD of the department was quickly called, got across to the doctor, giving the reason he gave, couldn't meet up the boss. Couldn't meet up the boss, the free boss was supposed to. You have star boss and we also have shuttle bosses that take care of people that can shift duty. So that was the cause of it. So she quickly calls another doctor that was around to fill that gap. So now, what will be done to that doctor? Doctor was queried. So we try to ensure that people are accountable and they lay down public service rules are followed even when you are dealing with your staff, because there's civil service rules, public service rules that are guiding us on how we handle staff that violate those rules. And it's very, very critical in the health sector because you are dealing with life. So we are trying as much as possible to ensure that that nonchalant attitude to work, that very poor work culture is reduced to the barest minimum. But people have different character traits. There are some people that we are even forced to suspend. Yes, suspend. There are some people that have been throughout, even porters for instance, they're supposed to move a patient from maybe AIE to the theatre, will not be on duty and all that. We have even recommended the civil service, or sometimes we've suspended, or some of the time we even taking extreme different measures against church staff. So when you have this kind of poor attitude to work exhibited by your staff, you can only talk to them and you also follow the public service rules in dealing with the situation. That is what.
So
Yeah, that's
the
what.
public service, we have in place public service rules,
Yes.
and then we also have rules that a structure you have set in, starting from your hospital that you're in charge of to deal with these nonchalant attitudes.
Yes.
And you're telling us that there has been this structure is working, and with time, this attitude would be reduced to its barest minimum.
Yes, because I will make bold to tell you that when you take disciplinary measures against erring staff, most of the time there is change in behavior for good. Most of the time, yes. Because, some even when they are respond to your query, they plead, that please, that they will not do it again and all that. Because there are rules. You cannot just sack somebody in the public service without following due process. So that's the way we are handling. But generally speaking, there is really needs, not just in our hospital per se. Generally speaking, all health workers in the rural areas, most hospitals should be given this orientation, and they are calling, and we have various, regulatory bodies that overseen various categories of health staff, and various regulatory bodies, and we swore to our oaths, like medical doctor, Hippocratic oath. Yeah, so we are supposed to abide by those oaths, and to appeal to their conscience, to have that change of attitudes, because your poor attitude could even affect your own person in service, because we've had situations like that even some years ago. Somebody that was supposed to be, even before this scheme came on board, but somebody that was supposed to be on call, went away, to do, and one of the excuses they give, let me just also mention it here, is that somebody that may be on call, so that he has left his duty post to go and look for food to eat. That kind of thing. So we have, restored canteen services, even doctors, nurses, all other personnel on shift or call duty meals. So you don't have any excuse to go out of the hospital that you are going to look for food to eat and all that. So these are all the measures that we're trying to put in place to ensure that people should know.
Right. Thank you, Prof. I think I have something, so I would want to put it to Dr. Becky, and then you then do a follow-up to that.
Okay.
So it's still on the issue of waiting time, right? So I'm sure by your experience you had that complaints too, right? And you also said something, and Prof said something about JAPA. So it simply means there's a challenge of staff shortage. And now we are having a surge. We have a scheme in place now that is on a daily basis. We are incorporating, onboarding new enrollees. So what are we doing? What are we doing differently in regards to filling this gap, making sure or ensuring that we having new staff to meet the numbers? Because I know the patient to doctors ratio is a problem. It has been it's a national problem. Should I say a national emergency? But at this state level, since we begin to spot these challenges, what are we doing to fill in this gap? What are the measures we are putting in place?
I would also want to add to that question, so we could address it at once. The issue of drugs shortage and doctor enrollee relationship. What are the measures we are using to address this?
All right. To answer that, Well, like you rightly mentioned, we have a serious death in a human resource for health in the country, not just Bayelsa State. So the number of health personnel over the years has reduced. Like it keeps going down virtually every year. Okay, so what BHIS does, we have what we call continuous utilization and
Continuous utilization,
monitoring.
monitoring.
Yes, continuous utilization monitoring. What we do it during that, what that simply means is, the scheme is running.
Yes.
So there's no break in between. People must go to the hospital.
All right.
Now we've accredited these facilities, we're giving accreditation to them to provide maybe primary, secondary, or tertiary services like NGTH. So we have staff that go out to these facilities on a weekly basis. Weekly. I mean, even these weeks, there are 2 persons have gone out. They will go around Yenagoa and other suburbs around Yenagoa, all facilities around there, including NGTH, to find out what are the challenges our enrollees are having. Okay? If it's drugs, if it's waiting time, anything, it might be other issues.
Mm-hmm.
Okay, it could be doctor-patient relationship, whatever the enrollee complains, we have to take it and then come back to the facilities. Now, we don't just rely on what the enrollee has said. Okay, we've gone to the facility, oh, there's a waiting time. What's the issue? Why? Oh, there are just 3 doctors consulting, seeing these thousands of persons, That's one side. What if it's at the pharmacy, or we've been buying drugs? We don't have, the facility has not been giving us prescribed medications. Now what we do is we go back to the management. Please, these are the complaints, the management of the hospital, I mean. These are the complaints we've been getting. Okay? We know there is a serious human resource for health, there's a disadvantage there. People are complaining that they've been sitting there at the reception or at the outpatient department waiting to be called. They've been there since 8. This is already 12. How is the hospital going to address it? So the hospital, if it's the private hospitals, they need to look for extra manpower. The government hospitals, they also need to look for extra manpower. But since it's a government facility, we also give that feedback directly to the head of Department of Medical Services, who in turn will give to the executive secretary, and then the board of the Bayelsa Health Insurance Scheme. In turn, will take that message to the Honorable Commissioner of Health, who will in turn inform the governor that these are the issues. Every facility our BHIS and enrollees go to, this is what we are having. There are no doctors, there are no nurses, and all of that. You heard Prof just said the government has employed or is planning to employ new health personnel. And I think an employment was done recently.
Was it 2023?
2022.
Some personnel are not.
Oh, okay, some personnel were
Yeah,
not.
not even by you could not even see them to employ. That's all.
Okay. So I know at the primary healthcare level as well, we're having that challenge. And Gavi UNICEF came up with this idea of employing adult staff. They signed an MOU with the Bayelsa State Primary Healthcare Board to absorb this staff at the end of the MOU, which was for 3.5 years. And I think that has been sorted because those staff have now been given their permanent employment letters.
Okay.
So, in a way, with this problem of human resource for health is being looked at and sorted. In the issue of drugs, now, you can't wish it away. It's not every time that facilities would have every drug. There are a lot of drugs. And then it's not every drug that is given as it should, free of charge, because the person is under insurance. Some are co-paid. We call that co-insurance. So the enrollee pays a certain amount for those drugs. So sometimes when you meet these people and they say, oh, I bought the drug, I buy. Personally, I would like to find out how much did you pay and where did you buy this drug. If you say you bought the drug in the health facility, I would like to know which drug. And if you call the name of a drug that is being co-insured, I have to tell you, sir, ma, this drug is co-insured, that's why you pay this amount. However, if the amount the enrollee mentions is exorbitant, above what you're supposed to pay in the tariff, we reach out to the facility. Look, your pharmacy, these are the discrepancies we found out. And then it will be sorted. So there's always a feedback, both from the enrollees and then from the facilities, to see how to iron out all our differences and issues. And it's for the good of the scheme, and to see that we have more people on board, and then at the end of the day we reduce the out-of-pocket expenditure. All right, so that's basically how we handle it. Prof has always been in touch with the agency. Always. In fact, before we started, we were just having a chit chat over there about some of the discrepancies, and I can tell you some of these things, they are not necessarily from the facilities, like purposely done from the facility end to see that enrollees are being forced to buy drugs or pay for services. Sometimes might be just ignorance on the part of whoever is there in the pharmacy. It might be an intern who does not know that this medication is supposed to be prescribed or given at this rate, or it's not available here, we should go to the central pharmacy. Not everybody that is coming in has this knowledge of insurance. So once in a while, we also like to go to facilities as well and give some orientation to staff. In the private facilities, there's a high attrition of staff. So the desk officer you meet this month might be different from the one you're meeting next month. We like to see that we reintegrate and reorient these new persons, that this is what health insurance is. When they come like this, you do this and do that, and give them always give them the BHIS guidelines, the benefit package, so that they know that this is what they should do and this they should not do. So there's always that interface between BHIS and accredited facilities as well as the enrollees.
BHIS committed